recently we had some crisis in our country, and we really need to know what to do with kids and what to do with our medical staff who were under a lot of pressure on these days. We are all ears.
Thank you so much. It's 8:01 a.m. here. Actually, I'm in California, not Canada.
I'm sorry.
Somewhere in the world, because tomorrow I go to Tokyo. So I'm glad this worked out. And it's. Do you want to give a few minutes for the residents to join, or would you like me to start?
I think we can start. We have
So
good amount of people here, and others can, because we are recording the session. I think we can
Excellent.
use the credits. But first, let me check something, and then we'll start. I'm so sorry. I will. Okay. Yes, everything is good. We're good to go.
Sounds good. Thank you so much for the introduction. I quite appreciate it. So first, apologies. I did not know that Google Meet does not share the full screen, so you will be seeing now non-presentation mode of it. So please try not to get distracted with the small slides on the left. I'll try to do my best to kind of go along with it to change the screen. But also, I cannot see you guys with with me trying to present with a PowerPoint. So I may not recognize if there's any questions or anything like that. So thank you for modulating this, Sevil. Appreciate it. So I am going to start the presentation. First of all, I have no conflict of interest as I was introduced, and I am a medical director slash counselor for the Mitsuke Kokoro Kids Salon. And what does it mean? It's in Japanese. Kokoro means heart. So it's Mitsuke is a name of a place in Tokyo. It's a city in Tokyo. We are the salon for your heart, your soul, and we are there for the kids and the children, parents, and especially for parents who is going through their children are going through the treatment or have a diagnosis difficult disease, and we're there to support the parents. And then what we are being recognized for in Japan, and I actually gave a presentation for the conferences in Japan. It was a triple conference for the Japan Pediatric Emergency Society and also the Pediatric Critical Care and the Japan Heart Association. The focus on our Kokoro Salon is to how can we provide support to the pediatric caregivers? Because really, isn't it, as Sevil was saying, that in order for us to give a good care, we have to recognize where we are in our state and in our current state, and then we must move forward. How can we be better at providing care? So let's see. Can you see this slide, caring for the caregivers? Is that the one that you see?
Yes, we can see it. And I'm sure people would have some questions. I encourage them to ask in the chat session. Even if they want to ask their questions in Persian language, I will translate it to English and we will cover all the questions at the end of session.
That would be wonderful. Or you can ask in Japanese too, honestly.
I'm sorry, I do not know that language.
Just kidding. So the caring for the caregiver's mental health. Insights from everyday pediatric practice and disaster response. That's what we'll be covering. And understanding the caregiver challenges and needs. And then the introduction to mental health support strategies within the system. And I'm glad the residents are joining because this is something that we are starting even in US and Japan. This is something new. And then I hope in Iran, before it's too late, we start supporting the mental health support strategies in every organization, every academic centers, internationally. And then I hope we can collaborate together in the future. So just the introduction of myself, because the name means nothing. So why am I here and why was I invited? And then I just wanted to introduce my backgrounds of where I came from and why I got to be in these positions and why I'm in Japan doing this work. So first, when I was a high school student, that's way back in like 20 years ago, something like that, I received a government scholarship to go to Japan and study. And it was scholarship to that picked 10 people. Two went to the United States, two went to Poland, two went to Germany, two went to somewhere else. And so 10 of us went all over the world with the government money to gain knowledge for Japan. And it was a scholarship. And then it was no need to return the scholarship for the studies. And our only requirement at that time of receiving this scholarship was that whatever we have learned, use it for somebody, use it to serve the country and an embetterment of human being. And that there was multiple scholarships out there, right? Like any scholarship that you can apply for. But that really resonated with me, to serve somebody and to study, to receive a scholarship, so to in betterment of a human being. And that really resonated with me and applied for it and I got it. And what I did with that is I went to Loma Linda University University for medical school. And it is this is a Loma Linda University. It is one of the 11 children's hospital that did exist in California. I believe there's only 11 still. And I studied here. And then after that, doing the medical school and residency here, next I went to the UCLA for pediatric ICU fellowship. This is I was trained to become a pediatric critical care physician and also critical transport physicians. And that I have learned quite a bit thanks to UCLA research, whatever else, and then appreciate my professors for that. During fellowship, though, this is where my fate turned quite a bit. I feel like in 2011, my country went through disaster, and as you know, our country is very much disaster prone. And then yet that was the biggest earthquake and a disaster in 100 years. Magnitude of 9.1 was measured, 9.2 was measured. And not only after that, tsunami came and a nuclear explosion happened. So it was considered triple disaster. And I was only second year in a fellowship. I hope there is a residents and fellows and whatnot in this. Even though I was a second year in a fellowship, I was deployed because there was no pediatricians that really survived this incident, and then it was devastating. And then I happened to be in California, in Los Angeles, about to take a flight going back to my tropical island, Okinawa. That's my home. Then I got a phone call from Japan, and it said, "Dr. Kozue, please take a look at the news." And I looked, and then that's when the tsunami was about to hit Tohoku, the Sendai. And so I got directed from that person in the phone call, please do. All the flights are canceled, but there's one flight that's leaving. Some of the flights are leaving, and then firefighters from LA and then the international rescue teams are coming. Please get on that flight and come to us. And as the Tokyo ends in back in a blackout, I left to go to Tokyo when everybody was fleeing, and I decided to go in to Tokyo to help out. And some of you guys may have experienced disasters in a recent, I know, chaos and wars, and in all these things, it changes you. Somehow, I thought I was quite a bit, already committed to my work and as a pediatrician, as a pediatric ICU doctor. But after this experience of pulling kids out of the water and not being able to save, and the feeling of I was there too late. There was no survivors after they were taken by tsunami, and most of the kids were either 100% okay or we couldn't do anything about it. And that feeling of I could have done more, and what can I do to change so this doesn't happen again? It really changed me as a fellow and motivated me. So after I came back from the disaster response, I joined multiple government programs, how to prevent disaster. So I was a consultant for the emergency response team EMS service for LA. So we created the pediatric search plan for there. I also consulted with National Health Ministry of Health and Human Services to create resources and aid for how to evacuate hospital in time of disaster. And then to the right, that's a Japanese journals for it reads Excluded and Invisible, and it's a special edition for about I think there was like 50 chapters or something. I was honored to be asked to write the first chapter, the opening chapters for this, Excluded Invisible Disaster in the Children for the pediatric. And then this shall be served as the guideline for our country to where we're going from now, what to do in a time of disaster. So after that, I moved after coming back from disaster and working this, and I joined the Kaiser Permanente. This is, if you guys have heard about private medical group in America, and Kaiser is one of the biggest ones and the most famous one, I believe. And it has about 31, 32 hospitals throughout California, Oregon, and whatnot. So that's one of the mothership hospital in Northern California that I worked for. I currently work as a pediatric ICU there and work for Japan as well, the Kokoro Salon. So that's my background, and that's how I started becoming interested in our well-being as a physician. And then in order for us to contribute, where are we at in our mental state? What is well-being? And then it's World Health Organization defined well-being as a state of mental health, mental well-being, and enables people to cope. One is coping with the stress of life, and then two, realizing their abilities, and three, learn well and work well, and the last part is the part that I really like, contribute to their community. So well-being is not just you wake up in the morning and it's like, oh, I feel all right. Not that. Are you coping with the stress? Are you realizing where you are? What can you do today? Where is your ability today? Can you learn and work well? And are you able to contribute to someone today? That's your well-being, and that's how you check yourself. Am I okay today? I really thought that this was a very good definition of the well-being. And actually, my neighbor actually happened to be a super famous person. He is a 95 years old engineer. He was a chief engineer for Apollo missions, and he designed the engines, and he's the guy who in charge for making space shuttles and everything else. So very funny, quick, 95 years old, still better at math than me as a 95 years old. And he comes over to dinner with me once a month or so. As a 95-year-old, Mr. Clay, as I call it, Mr. Clay wakes up in the morning and then talks to the mirror. And that's how he's been doing for last so many years, he says, as soon as he became a grown-up. He wakes up and then looks at the mirror and asks himself the same questions. Are you doing okay? You're looking pretty good. Are you going to be able to work okay today? Are you going to be nice to people today? And are you going to be able to serve someone today? And when I read the WHO definitions, I showed it to Mr. Clay, and he laughed, and he said, oh yeah, they stole it from me. So he's been doing it for so many years, and I feel like if he's able to make it for 95 years and he's still contributing, actually he was able to advise and consult with some of the Japanese aerospace agencies project when he was 91 years old. That's how I got to know him, actually. That's a good state of well-being, and he's my goal, and I want to be that person, well-being, somebody who can contribute to society no matter how old I am. So that's the definition. So where are we at in the medical provider? Is everybody okay still? All right. So where are we at? So how well are we as a mental health providers? not very good. During the after COVID-19, the state of medical providers' mental health went down quite a bit, as you know, and you probably experienced it yourself, myself included. WHO records that 1 in 4 healthcare workers reported anxiety, depression, burnout during COVID-19, and it's in a US surveys, it's even more. About half, 49% feels burnout, 38% feels anxiety. Post COVID, and remember WHO one on the left is during the COVID. Post COVID, it's not getting better. It's actually worse in the global review. Burnout is 44% and anxiety is 30%. So it's increasing despite the pandemic is over. Our state of well-being is being affected severely, as you can see from this graph. So burnout and its impact on the patient care. You don't have to raise your hands on in anything, but a lot of us attending physicians, even us professors who's teaching the residents and medical students, we feel that inside something is different right now after COVID. Burnout is very much affecting healthcare. And healthcare workers, as you saw in the last slide, is suffering from burnout and at the higher risk, which causes reduced attention and motivation, and it's increasing the likelihood for medical errors and also lower quality of care. And then there are multiple global studies that shows burnout nurses, burnout physicians, burnout professors are providing lower quality of care and the medical care is increasing, and then maintaining the physical mental health of the staff directly affecting pediatric patient outcomes. If any of you who's joining today is in the administration like I am, then this is something to note. It is really affecting the patient, not only us. And us pediatricians are worse because we are the nicest people in the medical field, I like to say, and burnout affects us worse. And it's the reason is pediatric stressors are more worse than the adult colleague of ours, because not just the patient, we have an intense family relationship, and also we have an exposure to end of life care of our children. And that's difficult because children shouldn't be dying before parents. Children should be dying before us. And that the loss of innocence and loss of children gives us not a sense of closure. And there's no sense of closure when children die. And there's feeling of guilt. And we feel more distress and ethical conflicts from it. Just going back to the definition really quick, and just so that we know what the difference between the burnout and the moral distress are. Oopsie, something I did changed it. So burnout is a condition caused by chronic occupational stress characterized by emotional exhaustion, depersonalization, which in medical field is known as a loss of empathy and caring, and reduced personal accomplishment. In 2019, the WHO recognized that burnout is actually an occupational phenomenon. It's in ICD-11. Moral distress is something different. That's something we feel ethically inside. And then in pediatrics, as I mentioned in the early slide, we feel this more. It's a psychological pain. We feel this pain felt in healthcare as a healthcare worker, as a physician, and then the provider. We are unable to act what we believe it's actually right due to institutional, because we don't have resources. I want to save, that's exactly how I felt, right? And during the disaster, I want to save this kid. But during the disaster, we didn't even have a paracetamol. How do we even treat a patient in front of us that's dying? How do we treat a patient when the government does not give us support to send us medications in the disaster zone, and then we couldn't even lift the patients up with helicopters because we didn't have any transport, air transport. That's a moral distress. Losing a life that didn't need to be lost. That's a moral distress that people feel, right? As a physician. And then even within the hospital too, we feel this every day. In ICU, there are sometimes we are pulled in directions. Family wants to do everything. This patient's already um, the quality of life is already sacrificed near drowners, but the parent family wants to do everything and wants to trick the patient to place a tracheostomy, G-tube, and a sustained life, although his function is already lost, the brain function is already lost. Kindest thing to me would be letting go, but family doesn't want to let go. But because family wants to do everything, then I have to place a tracheostomy. I have to do G-tube and then let this patient live. And that's a more ethical distress that I feel in a PICU on daily basis. So that's the example of that burnout and moral distress. Not only losing patients and then feeling pain inside because of the ethical reason and because we want to do good. We also, in the pediatrics and in the medical field, we are starting to have more and more harassment and violence in the workplace. Worldwide, the harassment violence against the medical staff is increasing. And this is one of the points that I'm working in Japan with the medical providers to prevent and also care for them. But 35% of the healthcare staff in Japan experienced workplace harassment. This is a report from a government survey. 35%, that's a lot. And you guys know Japan is a country of respect and politeness. And if we are seeing this much in Japan, I don't even want to know, right? Like in other places. That's how I felt when I first got this report. And in the same report, the national survey report, interesting enough, actually, this was not as I expected, I should say, the nursing staff, because they do spend a lot longer time with the patients and whatnot and at the bedside. So they have the highest number of cases reports for the harassment and violence, and then more than half experienced harassment in the past year. That's the report. But interesting enough that for the nursing report about harassment, I thought it was us physicians who was causing the nursing staff as harassment, but the reported, actually more than majority of the reported in nursing staff harassment was within their occupation. It was from their own leadership and their own peers. They were experiencing the harassment amongst the nursing staff, and that's something that we are focusing to. What can we do to prevent? And then so that's a work that's happening in Japan as well. And the residents, and we went through this, and I experienced it, and I think a lot of the attending physicians has experienced it. While you're in a training, we are most vulnerable to harassment, and it's disguised as a teaching. There's a surgeons who would hit residents with the instruments in the OR, and because residents weren't holding right and whatnot. That's my era. It's not happening as much in the US, but it's disguised as a teaching. And in an international meta-analysis, including several countries, more than half of the residents experience bullying or harassment by the attending physicians or nursing staff, and with female residents being particularly at risk. So prevention. So what can we do to prevent, as for prevention measure and safety of culture? And this can't continue. Otherwise, medical field will collapse, right? Burnout, moral distress, harassment, and violence. I feel like medical providers are under attack. And did I talk about this really quick? Hold on, let me go back. Oh, no, I did not. But anyway, so prevention, so that what can we do? So in 2022, Japan passed a law, harassment law, and it mandated clinic and inpatient hospitals, every workplace, to have a protocol in place and show it that our working environment is we are dedicated to improve that, and then there is a protocol for harassment preventions. So in 2022, that initiative, the government-wide was made. It made some difference. However, after that implementation, we still found out the pediatrics the most vulnerable because yes, we give physicians, nursings, and professional staff how to prevent harassment, sexual harassment, workplace violence. But the people who we cannot train are family, right? They come and go. So it can't be like, all right, we can how do we train families? We can't really, right? So then the pediatrics, we found out in pediatrics, actually majority, more than 10% of the abuse and whoever that's reported in the harassment in the workplace, it actually was experienced abuse from parents and families, including physical. And so that trend is actually recognized in the US and other countries. So internationally, okay, so now we train the staff preventing the harassment within our team. However, what can we do to teach the parents that behavior is not okay? So internationally, hospitals have adopted stricter rules, training, and agreements with parents, especially coming into inpatient unit, expected to be there for the longer stay. So Stanford Hospital. So that's something that we taking as a good example. They have a patient's rights and responsibilities, and this actually um, takes two roles. It explains the patient and parents, this is your rights. You can participate in the rounds. You can ask any questions. You're part of the team. You know, all these things. These are your rights. Then at the same time, they explained patients' parents' responsibilities. In it, it talks about you must maintain at all time respectful behavior to the medical providers. This was phenomenal. And then we adopted that, and then that we every time that we have a longer stay parents in the pediatric ICU, sometimes the patients are there for months, and when we start seeing the behavior that's problematic, this is something, then we talk about this and then we sign. What the sample does well is I heard that this is done at admission, so then it really cuts the problem at the beginning. And this was a great example of how institutional support made a difference in protecting the medical provider from harassment. Other things that institutional administrative leaders can do is really creating a safe environment, and then creating a response system and a support system. This is for the administrators and the medical directors and people who are involved. But residents, you're going to be one of them one of these days. I didn't think I was going to be when I was in pediatric intern, giving you guys a lecture and whatnot. But some of you will be. Some of you go to the clinic. And I want you to remember this. You have responsibility to create a safe environment, and bright lighting, elimination of blind spots, clear signature, and restricted access to sensitive areas. Don't let people in the places they don't need to be in. Panic buttons and alarms systems for immediate support. I learned this is so important because as a human, we always think that, oh, this is not going to happen to me. That's going to be okay. But you have to remember, one of the highest rate of retaliations and of violence is ICU and emergency room. A lot of us work there. And for us to be safe, we're going to have to check ourselves. Is our environment design safe? Do we have a blind spots that we can be attacked? Do you have a panic buttons? And then this came in very handy. I actually was part of the team when there was a gang member that came in and started shooting because opposing gang members' kid was admitted in the PICU. And then in a PICU, we have oxygen, and then the firearms, guns, and oxygen doesn't mix together, and it should never be mixed together. So when they start shooting, tried to shoot at us in the ICU. There was a panic button that was in PQ, and then we were able to actually call the security and the police right away, and then nobody was hurt. No explosion either, which is always a win, I think. So in a rapid, and I talked about another prevention is to have a rapid response to the incident. In North America, do we have this in Iran? I want to ask afterwards. But North America, we have a code gray system for threats, verbal abuse, and violence. And then so when we call code gray overhead in the operators and whatnot, it goes to the entire hospital and even in the clinic on the campus. And what happens with that is a trained staff team, like such as security, medical staff, sometimes social workers, or just nursing and physician leadership goes to handle to de-escalate the situations and then lead the team to safety. So we are all humans. Whenever we get into this code gray situation, we don't know what to do. And when people are attacking us and yelling at us, and then kind of some of us goes blank. Oh, we don't like confrontation. So it's a great way to have people on the team come and then know what to do, have been trained to do, handle de-escalation strategies to deal with it instead of us trying to put ourselves into it. So this is a good response system. Europe has the same thing. It's called violence response team. And the core principle of any country who has this violence rapid emergency response teams are detecting the early warning sign when things are starting to get, oh, this is not good, that the feeling that's not going, something's not going well, you can detect it early. And this is the part I really appreciate, the preventing stuff from being isolated in dangerous situation, because no violence, but some of them is no violence starts from nowhere, right? It's like parents are starting to get angry, they're starting to raise voices and this and that, and then you don't know what to do, and then you don't want to take care of the situation alone. So having a team around there and then not being alone gives you a good support inside. Okay, I'm supported, I'm going to be okay. That feeling is great. And also clear reporting routes, because one of the things nursing staff and then the residents, we don't report violence and workplace harassment, even though the parents are yelling at us, because one of them, we feel like we are strong, we can take this, so we should be able to handle it. We don't want to bother anybody. It's our commitment, very noble. And two is because documentations. When we want to report harassment and the violence and whatnot, is tons of documentation that's included. But once you call this rapid emergency response team, it's great. They have a reporting system. They document who, how, when, and then they reviewed all of these documentations, and then they come up with the prevention plans. Oh, next time we do this, and then it's actually contributes to the betterment of safety in the hospital. So it's a very good system. It doesn't burden the people who reported it, and it really keeps the record in the right place so that it can contribute to the future. And it's a real-time response, as I said. Okay.
Dr. Shimabukuro, I'm going to answer your question. In Iran, actually, we do not have that rapid response system for the security, but we need to take the phone, we need to call the operator, then she needs or he needs to page the security, and then they come. And we do not have panic buttons. I'm going to ask you something before. I'm sorry, I'm interrupting you, but I think it's a great time to communicate too. About this code gray, do you need to use the phone, or is there a button for code gray? Is there a microphone everywhere, or how do you use that code gray?
Code gray is called by over the hospital phones to the operator. So somebody who is witnessing, if you're by yourself, just call the video pitch phone right away. Don't hesitate, right? But then somebody who is in the team, because usually when these cases come in, then there is a witness around there. And so if somebody's being attacked, whatnot, then another person at the nursing station, whatnot, activates the code gray, just like code blue. We take this seriously. And when the code gray is activated, and then its response time is measured, and how many minutes did it get there for the key person to be at the scene and everything else. And then it's reviewed in a monthly environmental committee environmental EOC, environmental committees in the hospital, so that the CEOs, CFOs, everybody is debriefed on that. Yeah.
Thank you so much. And I'm sorry to interrupt you.
No, that's okay. I like it. I hope everybody's not asleep because online meeting is so hard, right? So,
Yeah.
any questions if you want to invite, then I think it's a nice way to take a break, so I don't fall asleep. And then,
Yes,
so I know where I'm at.
yes, again, I'm encouraging everyone to ask their questions, and I'm going to ask you to just tell one sentence in Persian language for people who would have problems in English. دوستان لطفا اگر سوالی دارین در قسمت چت بپرسید، من به انگلیسی ترجمه کنم. I'm sorry, I was just translating what I've already said in English. And I think we have enough time to drink just a little bit of water and then continue.
All right, sounds good. So after this violence in the hospital and the cold grace cause and at home, it's a good idea, just as I was mentioning, Sevil, for the leadership to be notified. We cannot ignore this, right? Because in a post-incident, we need to offer this psychological support. And this is where we need our psychiatrists and the counselors in the hospital for the staff. Counseling, debriefing, regular follow-ups for affected staff. When I got involved in disaster, or when I got involved in this near shooting event at the ICU, do you think I was affected? I was just a fellow, right? Of course. I didn't want to step in the ICU ever again. I was like, oh my God, we get shot at and then we could explode because we have oxygen, so that's not a good feeling. So I'm laughing right now, but thanks to the counseling that I had after this. But I know that I'm safe and I know my leaders. I can trust my leaders. They are doing everything they can. So I can confidently work in my workplace. And so really the post-incident psychological support reduces the trauma and stress through timely interventions and building a workplace culture like, oh yeah, I can talk about this. There is a support. There is not to blame, or you have only done this. Not that kind of blaming cultures, but the supporting culture. And then, as I mentioned earlier, I felt safe afterwards. The staff feeling safe, sharing experience, and being back to work again is critical for us to keep our medical providers healthy. And then, as I mentioned, another stressor, inevitably so in our country and also anywhere in the world, disaster, natural disaster, human-made disaster is something we cannot avoid in this modern day world. And again, this is a moment that we feel another critical moment for providers, pediatric providers. In a pediatric disaster medicine, we are known to be excluded and invisible. Pediatric healthcare, in fact, I think this was from WHO as well, the guidelines and whatnot, that is a title, excluded and invisible. It is a reality of pediatric medicine, and especially in disaster medicine. I mentioned briefly that when I was deployed in Fukushima, we didn't even have a paracetamol. We didn't even have anything like pediatric adapted equipment, intubations, ventilator, nothing. We are forgotten, and then we excluded and invisible when the government does planning, right? So this is quite odd because over the past 20 years, every large-scale disasters have affected tons of children, as you know, and then somehow, despite children being the huge part of the disaster victim, children remains invisible. In the U.S., in the DMAT report, last several years, the disaster affected 30% of children. And then out of those 30% children, more than half of these victims were less than 4 years old. So, do you think adults can take care of these children? Not really. We are pediatrician. We can take care of the less than 4 years old better than that. But however, because there's no government and an institutional support for this, children loses their lives because of our unpreparedness, and then unnecessary death leads to moral distress. Our heart sinks every time we lose that life. So as in more and more disaster and also in hospital care, more and more we experience this. We could have done more. We lost a life that was unnecessary to lose. This leads to what's called a cumulative grief. The effects are everywhere in our in it affects all of us, I should say, every single part of us. Emotionally, we feel guilt, helplessness. Physically, we feel insomnia, have insomnia and fatigue as one of the main. Somebody needs to mute them, huh? Mute themselves.
I will do this just a minute. It's my friend Sheet, and I think she's having a call. Let's find her, and I would.
I'll wait. Don't worry.
Okay, it's all okay. I'm sorry.
Oh yeah, that's fine. Good. As you saw earlier, my cat came into the screen, so there's interruptions. So physically, insomnia and fatigue affects us, and then behaviorally, we avoid going to work. Or a lot of us, actually, the pediatricians are noted, instead of avoiding, we tend to overwork because we couldn't save that life, because we could have done more. Then we commit working more, coming into work more. I can do more, I can do more, and that actually leads to burnout. So it's not a healthy way of dealing with it. And then what happens with that is a team-wide impact. As I said, it affects all of us. With this cumulative stress and grief state, nobody can function normally. So that's the reason why we are now recognized. Just now we are starting to be recognized. Oh yeah, we do need support for the medical health providers. Supporting the second victim is something that in Japan we're starting to just focus on. And I think, in fact, as I was talking, we are the only clinic in Tokyo and in Japan that focuses on the medical providers to provide that support, much needed support. Second victim, that's us. We feel it. And then because we feel like it's weak to talk about how we feel, we become often silent. However, when Japanese government and when we do survey on the medical providers, for example, Fukushima survey, we surveyed shelter teachers and also the medical providers. 42% of the shelter teachers couldn't maintain emotional stabilities after their village, their town, their city is engulfed in tsunami and was taken away. How can you? Their wife died, their children died, but they continue to work, and then they felt broken. That's the word that they use. They felt broken. They kept going. Japan DMAT responders, same way. Within 4 years, majority of the responders felt PTSD, burnout within 4 years, and they did not feel like they can sustain their work in the field, not just in the disaster field, but in their own clinic and the hospital. So you can see the common challenges in the pediatric hospital and disaster, really emotional burden accumulation, limited structural support. We're still a baby stages for this. Now now for the first time we are recognizing we are the victim of multiple challenges that we face. And then there is no structures to support in the countries, government-wise, institutionally yet, and organizational undervalue the staff of well-being. We probably experience this, right? Like in ICU, patients die, and during the round, you resuscitate, the patient dies, and we just say, okay, some residents are crying, students are shocked, and they can't even comprehend what just happened, but we just say, okay, let's continue with the rounds. We do have to, but we cannot stop there. We cannot undervalue the staff's well-being. It affects us. And in order for us to start recognizing and supporting it, we definitely need leadership commitment. I talked about in most of the government and including my own Japan, somehow children are excluded and invisible. Pediatricians are too. We are excluded and invisible because we are kind, we are committed, and we don't speak negative things as much. But it is our job, isn't it, to let the leadership know this needs to change. This needs to be brought up to the attentions of a hospital leadership, government leadership. We need to start supporting medical providers. This is what we, after the 2011 experience, we learned from our mistake. And then there is now a disaster psychiatric response team, DIPA team in Japan. And that communication, their care models for responders, I adapted to my clinic as well. Communication, ask, rest, eureka. Care is the acronym for that. Focus on the human connections, just not just procedures. Build a culture and a system to ask for help. It's okay to ask for help. It's okay to say I feel broken. And mandatory rest, and that's something that we have to take care of our residents and the people who's coming behind us. When we were training, it's okay not to sleep, and I think there was a saying at UCLA: "Sleep is for the weak." That eating is for the weaker, but it's not. Rest is mandatory, and we need to sleep in order for us to continue to be kind, dedicated physician. And then long-term psychological support and follow-up, and that's something the leadership needs to provide. How can we support people who experience trauma? Example of structured supported systems is just an example that I'm suggesting to the hospitals in Japan and whatnot. Where is a structured support system, standardizing grief conferences after patient's death, developing grief response manuals and handbook for the residents and the medical staff, and publicizing the availability of mental health consultation services to staff. There is usually none in Japan that's dedicated counselors and whatnot, mental health support team in Japan. So that's why our clinic takes a referral from the every hospitals in the greater Tokyo to support. And regular grief rounds is recommended in the hospital. Now, what's a grief round? Just quickly, it's in there, fostering the culture, and the managers and leaders go around once a month and every week, or when they get the report that this terrible thing happened in ICU, patients died in ICU and in this way, then they go to the units and say, how are you doing? Was the recent case difficult for you? So talking and asking for help becomes normalized in the institution. We have to take steps for that. I'm publishing, my book is coming out, and I focus on the pediatric mental health. It's coming out in Japanese, in Japan. And then we focus on this quite a bit, medical providers and how we structure support system in the hospital. And then providing the psychological long-term. We usually recommend at least 6 months after the incidents, and then build resiliency, and then being able to carry the grief with you and move forward. And this is our Mitsuke salon advertisement, not advertisement, handout whenever we feel like the hospital staff needs it. This pamphlet is in the ER, pediatric ER, and also in the pediatric ICU, so that way the medical staff can easily contact us. And it's actually, I don't know if I mentioned this, it's actually run by a funding, and so counseling is free. So it's a community of people. The funding did not come from the government, interesting enough, that when I start realizing this medical provider needs a support, affluent people, the company's presidents, and the people who have a lot of fundings to help others, they actually donated money to establish our clinic, and then all of our counseling is supported by the community fund that is donated by the sponsors. We have a partners and sponsors who help. And it was a really good way of showing the country. There are people within the country that cares for us, cares for medical provider. We're not alone. People in the community actually wants us to be healthy. They want to support us. I kept saying leadership needs to be involved. We have to talk to the leadership. But you know how long it takes for the government to start moving or the hospital administrators to approve something that we desperately need. It takes years, but we can't wait for that. It's happening. Disaster is happening right now. Trauma is happening right now. Burnout is happening right now. So what can we do? And the community reached out and helped. So this is a good model of really, we started in Tokyo, but we intend to spread it everywhere that we we can contribute. We don't have to wait for somebody else to say you can't do this. We can. If we wanted to be that somebody to start changing the system, might as well be that somebody. We're all humans, not superheroes. I learned that through experiences working in ICU and also working in the disasters. For me to be healthy, for me to be in that state of well-being, it's necessary. Without that, we cannot move forward. We care for children, we have to be healthy. So we need to recognize within ourselves, caring for us sustains, saves life. It sustains care quality. Caring for us makes the children live longer, and it makes the, as a result, your country, my country, will be have a better, bright future. Let's establish formal support system. Let's encourage open discussion of emotional impact and foster the culture. It's okay to ask and then care for. Let's care for the people who caring others. As I said, leadership is playing a key role in sustaining caregiver well-being. But don't wait for somebody. Don't wait for the leaders to do something for you. Think and then let's do something that we can support ourselves. That is the end of my presentation.
Thank you so much. Thank you for this actually insightful presentation. And again, I encourage everybody to ask the questions. I see Sarah has raised her hand. Sarah, how can we help you? Sarah, you have raised your hand. If you have any questions, you can turn on your microphone, your video, your camera, or you can write in the chat section. Or if it's an incident of touching the screen, please let us know. Okay, so today, Dr. Talebian, thank you so much for joining us. Everybody, if you have questions here. And I'm waiting for guys to write in the chat section, and I'm going to ask my question. You said something about the guidelines, how to evacuate the hospital. Do you think in the future we can have some time talking about those things too? Because in the hospital that I am working, this happened 2 times in 12 days, and it was so distressing, and we actually didn't know what to do. My greatest friend, Asma, managed that well, but we need to know what to do. We need to be prepared. Do you think you can share your protocols with us sometime in the next months, maybe in the next 2 months?
Of course, yeah. The ones that I got involved as a consultant is in 2013, and then since then, based on our recommendations, because that's exactly what we did during 2011, right? Evacuating the hospitals quickly when we are under attack by nature this time, and since then there has been much improvement and a more protocol that's been available. So whatever I find, and then including with our original ones, and I'll be able to provide that to you. It is critical that the leadership knows how to do this and train the providers how when this happens, not if, it's going to happen, right? In our countries, something's going to happen, then we need to know how to provide for that. And not only that, I heard afterwards, or after that we evacuated, and then there are survivors, and in order to care for the medical providers survivors, we also have to put that in the protocol as well. Yeah, so I'll be happy to share. Okay.
Thank you so much. And we have a question here. Dr. Taliban has asked us, in your hospital, do you have systematic screening programs for evaluating mental health of medical staff?
Good question. Evaluating the medical staff, not zero, even in America. Japan, even worse, right? We don't even have anything really. The PSQs, the depression screening and whatever else, that I encourage that should be done. And then we talk about that in our book. I said my book is going to come out, but it's actually a collaboration of the mental health providers throughout Japan, the entire country. We pick the key stakeholders to write chapters, and then one of the chapters for that is actually suggesting the leadership to, one, do the grief conferences, as we talked about, grief rounds to check on the each unit. How is the each unit? That's eyes on is important as a screening. And two, that asking the providers to fill out how he feels. But the thing about the medical providers, as you know, we're busy. So when there's like email, fill this out for me. This is a PSQ questionnaire, and like you can. I'm going to screen for depression and anxiety, and they said nobody does, right? Like nobody opens that email anyway. It's like, So the most important thing is focusing on the target, like knowing where is the stress in your organization. Ears on, eyes on. Like I think that really helps. So once you know that, like, okay, this was affected, this oncology kid who we cared for since 7 months old just recently died after significant battle against the cancer. We should know as a leader, and then go to the care providers. I heard so and so died. Can you tell me about it? It's better than screening, isn't it? And then you feel hard. I think that's a better approach when it comes to physicians, for sure, because we do not fill out surveys. I have learned.
Thank you so much. And I have one more question myself. Do you perform these grief rounds on a regular basis in America, in Canada, in Japan, or somewhere else?
Yeah, you cut off a little bit. I perform this grief round based, what is it again?
In your country, I just was asking if you have performed that round, and if yes, just the medical staff was there, or even the parents were there, even the security guard, and who else was on that round?
Oh, good question. Thank you so much for asking that. So the grief rounds in Japan that we are suggesting to do is, it's an open invitation. It's not mandatory. And then we focus on three things. Like we talk about what's your relationship with the kid. What do you remember about this? This is not like a post-code, let's debrief. Completely not unrelated with the medical things. We talk about how do you remember the kid? What do you how do you remember? Let's say Camila. What do you remember about Camila most? This and that. So that okay, get that. So what is the part that you're struggling with? So it becomes more emotional grounded one. That the open invitation, it goes to staff, including physician, nurses, students, no parents, but usually a lead is a psychologist or psychiatrist or social worker leads that. And then it's even security people go through grief and trauma too, right? Because they witness children dying as they're trying to do a number control. So we invite staff mostly. This is for staff. And then for parents, there's a parents grief session. But you probably is same in Iran too. Like Japan is very much a not secretive, but we want to be respectful, so we don't feel comfortable pouring our feeling out and talking in a group session, which works in Northern America. That will never work in our country. So What we do is that we give a grief card. It's I should have had it in the presentation. When the patient dies, we give this very message, like a poetic message about how we are with you. We feel the pain of you. When you're feeling ready, call this number. We are here for you. Access this website, which is our clinic. Um, we can talk to you about that. So that's how we offer grief to the parents separately.
Thank you so much. And I have wrote a very precious sentence. The first thing you said in your presentation, did you serve someone today? And from tomorrow on, I will ask this very question every single morning and every single evening for myself: that have I served someone today in the hospital, in the workplace, or not? I think there are no more questions here in the chat section. So on behalf of the organization committee, I would like to thank our speaker and our participants for this valuable contribution. I would like to express my sincere gratitude to Vice Chancellor of International Affairs of Tehran University of Medical Sciences, as well as Dr. Ziai, Program Director of Pediatric Department, and Dr. Behdad, Gharib, my dearest friend, whose support made this event possible. And I really do hope that discussion will inspire further research, further advocacy, and action to support children and healthcare providers as well in times of crisis. Thank you again. Thank you so much for joining this event. I know that tomorrow you will have to travel, so it was a short notice. Thank you for joining us. Thanks your cat for joining us. I love cats. I cannot stop talking about cats.
Thank you so much. Yeah, and then I think my email is provided to you guys. And then if the residents, students, anybody who is interested, and do contact me, I'll be happy to help out. And if there may be somebody who is who wants to do a similar thing, establish a system that we were successful in doing in Japan, I'll be happy to guide you through that, because everybody needs it. And then two, that, or even if you feel like, shoot, I'm that person, I'm feeling burnout, I'm feeling moral distress, I need somebody to talk to. And then again, we are one online click away. I'm here for you to listen. Yeah. Okay.
Thank you. I will make sure to share your email address with the residents and fellows and my colleagues. And thank you again so much. I think it's 7:30 p.m. in Tehran, so it would be 9 in California.
That's right. Gotta go to work.
Good mathematics. So, thank you again for this participation, and I would have to say goodbye till the next session. I think we would love to talk more about how to evacuate, and about evacuate the hospital, and about the protocols too. Thank you so much, and goodbye.
Thank you so much.
Bye-bye.